Hi, and welcome to our education program on vaccines and testing. Over the next set of 3 modules, we'll be addressing several issues related to COVID-19 testing and COVID-19 vaccines. Our very first module is on vaccines and health disparities. Let's address disparities in vaccination rates. The 5-module series, of which this is the first, involves vaccines and health disparities, vaccine hesitancy, patient communication techniques, and COVID-19 vaccination education, completion of the city research certificate training, and then finally, a live question and answer session. The very first module, Module 1, will be presented by Xavier University's Dr. Martha Earls. Dr. Martha Earls is a clinical assistant professor in the College of Pharmacy.
My name is Dr. Martha Brown Earls, clinical assistant professor here at Xavier College of Pharmacy. My information is shown here. Please feel free to contact me if you have any questions. Martha Brown Earls, myself, I have no relevant financial relationships or commercial interests to disclose. The objectives of today's presentation are: 1, to discuss Healthy People 2020 goals and disparities in vaccination rates in the United States. 2, discuss disparities in rates of COVID-19 infection, hospitalization, and death by race and ethnicity. Thirdly, we'll promote pharmacy-based strategies to A, decrease vaccine hesitancy, B, increase vaccine uptake. So let's take about 2 minutes to think about this case. How would you respond to Jill's comment? Also, what vaccines would you recommend? Now, this is a different case scenario. Take a few minutes to think about what vaccines you would recommend and how you would handle the question asked by Mr. Johnson. We will discuss both of the cases during the presentation. Let's start by looking at a definition of health disparity. Healthy People 2020 defines health disparity as a particular type of health difference that is closely linked with social, economic, or environmental disadvantage. And this occurs if the health outcome that you see is to a greater or lesser extent in certain populations. When we look at the determinants of health, it is humbling to us who work on promoting better clinical care that our biology and clinical care accounts for a very small percentage of the health outcomes. Our challenge is to translate this into action. Now, this slide shows the elements of the social determinants of health. Though healthcare is essential to health, research shows that health outcomes are driven by multiple factors, including underlying genetics, health behaviors, social, environmental factors, and access to healthcare. Therefore, disparities can occur across socioeconomic status, age, geography, where you live, language, gender, disability status, sexual identity, and orientation. As pharmacists, we can address these issues, which are so important. Adult immunization really are a critical way to prevent the morbidity and mortality that comes from vaccine preventable diseases. This slide helps us to understand key facts about adult immunizations on a granular level. Why most people might think of disparities specifically by race. Adult immunization experience can also differ by age of the adult, healthcare personnel, and other factors. So you can have racial disparities among older adults. For instance, whites aged 60 years or older currently have higher shingles vaccination coverage than those who are Black, Hispanic, and Asian. Now, among young adult women aged 19 to 26, we see once again non-Hispanic whites having higher HPV vaccination rates than others. When we think about health care personnel, it's interesting to think that there would actually even be any vaccination disparities among that group. But in fact, there are. White healthcare providers have higher Tdap coverage than their Black and Hispanic counterparts. When we think about adult immunization disparities, it's important to remember that these disparities are systemic. They are avoidable or preventable, and in fact, they are actually unfair. We're going to look at the major vaccines where there are racial and ethnic disparities. We'll start out first by looking at influenza vaccine coverage. This figure shows influenza adult vaccination coverage in the United States from 2010 to 2020. When we look at flu vaccination coverage, overall, among adults, the coverage is about 48.4%, which is 3.1 percentage points higher than the coverage during 2018-19 season. Flu vaccination coverage for 2019-20 was higher for every age group compared with the 2018-19 season. Also, we observed in previous seasons that the flu vaccination coverage was higher for older adults when we compare that with younger adults. So let's look at adults 18 years and older for the 2019-20 season by race and ethnicity. You can see that the overall coverage is about 48.4%. Whites had the highest coverage of about 52.8%, followed by Asians with 52.3%, then American Indian and Alaska Natives with 42.3%, Blacks with 41.2%, and then individuals who reported other with 40%. So now we're going to look at the pneumococcal vaccination coverage. When we look at pneumococcal coverage for adults aged 19 to 64, those at increased risk, we see that this vaccine in terms of uptake is greatest among the individuals who reported as other. And others include Hawaiian, Pacific Islander, and multiracial. But when we look at who's second highest with uptake, it's Blacks with 25.7%, followed by Asian, white, and Hispanic. Now, something that I'd like to note here, even though it's not here on the slide, when we look at vaccination, pneumococcal vaccination by those who are 65 years of age and older, it showed that whites had coverage of 72.6%, which was higher compared with Blacks, who had 59.8%, Hispanics 55%, and Asians 54.3%. So now let's look at the progress that has been made toward Healthy People 2020 for the pneumococcal vaccine. Now, for pneumococcal vaccine specifically, the goal is 90%. So what do we see? For those individuals who are 18 to 64, we see that we are pretty far away from the goals of reaching Healthy People 2020, whether you're in Alabama, Georgia, Illinois, or Louisiana. However, when we look at it for individuals who are 65 years of age or older, you can see that we're actually getting closer to the mark. Now, on the next slide, we will see that in fact, when we look at it now by race and ethnicity particularly, we can see again racial differences. While comparing the greater than 65-year-old individuals by race, we see that the whites that are non-Hispanic are closer to the Healthy People 2020 goals than Black, non-Hispanic, and Hispanic population. So let's look at those who actually report that they are other or multiple race and non-Hispanic. They actually come the closest to those who report as white in terms of approaching the Healthy People 2020 target. So now I want to draw your attention to herpes zoster vaccination coverage. When we look at herpes zoster vaccination by race and ethnicity, we can see very similar to others that in fact, the white race is actually reporting higher vaccinations, followed by those who report as others. Then Asians with Hispanics and Latinos following, then following by Blacks. Now, I would like to make a note here that herpes zoster vaccination coverage met the Healthy People 2020 target of 30% back in 2015. However, even in 2021, there are still some races and ethnic groups that have not reached the target. Now, this slide shows us about healthcare personnel, race and ethnic group vaccination differences. Here we see that the uptake patterns are similar, but thankfully, the uptake among individuals who are healthcare personnel are greater than what we saw in the uptake of the general population. So, what is it and where do we see this? We see this difference in healthcare personnel by race and ethnic barriers and vaccination variation. So let's see if we can figure out what might be happening by looking more at these two graphs. What we can see here is if we look by occupation type, that in fact, the lowest percentage vaccinated is occurring with assistants, nurse assistants, and nurse aides, and also individuals who are non-clinical personnel. So maybe there's some differentiation about what races and ethnic groups are in which particular occupation type. And so we can also now look at the work setting. And what we see here is that long-term care settings have the lowest vaccination rate and hospitals have the highest. So in fact, the distribution of our workforce, in addition to occupation type, may contribute to the differences that we see by healthcare providers. So we will switch gears and talk about the biggest public health concern we are facing today, the COVID-19 pandemic. So, people of color are disproportionately affected by COVID-19. Now, the reasoning behind this, we believe, is multifaceted, a combination of factors. And so we'll now begin to look at some of those factors individually. One is predisposition to chronic disease. African Americans have higher rates of diabetes, obesity, hypertension, heart disease, asthma, and other medical conditions. Now, many of these conditions have been linked with more severe COVID-19 infections and poorer outcomes. Greater exposure to viral infections. People of color may have greater exposure. So while US residents have been instructed to use social distancing and other tactics to mitigate COVID-19 transmission, it's easier said than done in some communities. Many people of color live in apartments or housing complexes where distancing from other residents is nearly impossible. Not only that, those who rely on public transportation have the same challenge. Now let's look at lower health literacy. Understanding your risk factors and taking steps to manage them require a certain level of health literacy. People of color tend to have a lower level of health literacy, which amplifies their susceptibility to disease, especially during a pandemic. Now, these factors are not new to COVID-19. During the H1N1 epidemic in 2009, we saw the same effect. 11 years ago, H1N1 did not receive as much media attention as today's COVID-19 outbreak, partly because social media wasn't as pervasive and government officials did not mandate shutdowns. So let's look a little closer. Age standardized data show that Hispanic, Black, and American Indian or Alaska Native people are at least twice as likely to die from COVID-19 as their white counterparts, and that Hispanic and American Indian or Alaska Native people are at nearly 2 times greater risk of COVID-19 infection than their white counterparts. This data also shows large disparities of COVID-19 hospitalizations for American Indian or Alaska Native, Blacks, and Hispanic people. As we look at the percent of total population that has received a COVID-19 vaccine by race and ethnicity, from March 1st to May 10th, 2021, we see vaccination rates are increasing across the various different groups. However, Blacks and Hispanics are facing persistent gaps. Now, the COVID-19 pandemic has made clear the essential role pharmacists play in immunization. Some surveys have found that many patients prefer to get COVID-19 vaccines at their local pharmacies instead of large mass vaccination sites. Now, we will look at strategies for immunization improvement. We will proceed with a brief review of current adult immunizations and rates. Then we'll look at case-based review of adult immunization, and then end with strategies to help decrease vaccine hesitancy and increase vaccine uptake. I know that you are all very familiar with this table, the CDC's recommendations of adult immunization schedule for 2021. This table helps us to identify who needs to be vaccinated, what vaccine they need, and when they should receive the immunization. Now, this table too provides the recommendations for high risk and special populations. A suggestion is to have these tables readily available in your community pharmacy for quick access. Now, unlike childhood vaccination rates, which are good, according to the National Health Interview Survey, we see that adult vaccination rates are poor. So if we look at influenza for all adults, we have less than a 50% rate for influenza immunizations. And for those who are younger, we have even a worse vaccination rate. You see, it's in the 30s. However, we are improving. And you see that from 2016 to 2018, immunization rates for influenza and pneumococcal vaccine have improved. Now, when we look at shingles, in 2016, the rate was about 33%. And in 2018, it was up to 34.5%. So we're improving, but there is still much work to be done. Okay? Now, the previous slide gave vaccination rates by age. This particular slide shows pneumococcal vaccine for adults 65 years of age and older, but it's by race. And this reinforces that we have minority populations that are achieving lower rates. Unfortunately, there are similar disparities for most adult vaccines. And this is unacceptable here in the United States. Therefore, this is the reason why pharmacists are needed to help with vaccines and health disparities. At this point, we will talk about some approaches that we can use in our pharmacies. One is to assess immunization status. And how we can do this is we can review our patient's profile for vaccine eligibility. And you might be wondering how we can do this. We can do this by using our technicians and or students or interns, having them to reach out and assess the need for immunizations. In some of our pharmacies, we have health and wellness calls. This is where the pharmacy calls the patients for their refill reminders. And it's at this time that the technicians and or students can reach out to our customers and to offer vaccines. Secondly, we can make a strong recommendation to our customers for indicated vaccines. Thirdly, we can directly administer the immunization if the patient agrees. Last but not least, we should document the vaccines that are received. That is of utmost importance. So now let's look at case one. This Jill may be a typical type of patient that we might encounter in our pharmacy. Now, Jill is a 42-year-old high school teacher who has asthma since childhood, and she's at your pharmacy to pick up her inhalers. She has been using her controller and needs her rescue inhaler about once a month in the fall, winter, and spring. Now, the last time that she was in the pharmacy, you realized that she refused recommended vaccines. And she stated that she didn't need them and that vaccines were for sick people. Okay. So, how would you recommend, or what vaccines would you recommend for Jill? And then how would you respond to Jill's comment? Okay, so I hope your answer is that you're going to make a strong recommendation to vaccinate Jill. And your reasoning for this very strong recommendation is because asthma is a high risk condition. Okay, so you would definitely recommend influenza. You would also recommend for her to get the polysaccharide vaccine, the pneumococcal polysaccharide vaccine, because asthma is an intermediate risk for pneumococcal disease. And if she had not received the Tdap as an adult, we would recommend that she get the Tdap. And once she gets that, then she could resume getting a tetanus booster every 10 years. Okay, so to go along with recommendation, we realized that Jill has refused to receive vaccinations in the past. So just to help you, we're going to go over two principles that you can use when you're recommending vaccinations to your customers. Number one, we want to do our best to be non-confrontational. And that is that we will do our best to recognize the reason or reasons why they may not want to receive the vaccination. So once we recognize, then we want to try to turn or motivate them to receive the vaccinations. And we want to make sure that we try our best to avoid emotional reaction. The second principle that we can use is to be supportive. And so what we can do here is to share our experience with receiving vaccinations to further promote the benefits of receiving vaccinations. And we can also include that our whole family has received the influenza vaccine, and sort of let them know that myself, as a pharmacist, I have received all the vaccines that are recommended for me every year. And I believe that this is very important to help me in protecting my health. Then, being supportive, we also want to acknowledge the person's beliefs without being judgmental. So these are two principles that we can remember to use when we are recommending vaccination to our customers. Now, you may have reached a situation like with our patient here, our customer Jill, who has not decided to receive their immunizations. So we can use what is called the share model. Here, the S, we share reasons why the recommended vaccines are right for the patient. We sort of try to help them to understand that receiving these vaccines will help with maintaining their health and wellness. The H, we want to highlight our own experiences with vaccination. So we highlight stories about our vaccination experiences. A, we want to address the patient's concerns and fears. We want to try and dispel common myths and misconceptions. We also want to make sure that we include the risks that may come from the vaccines. We may want to tell them about some of the mild side effects that they may get from the vaccine. And we want to make sure that we are addressing their questions and concerns in simple and plain, understandable language. Or we want to remind the patients about the risk of vaccine preventable diseases that could turn out to be serious and affect their health. And then the E, we want to be able to explain to them the potential costs of getting vaccine preventable diseases, and including in our explanation about missing time at work, about the additional financial costs that it may allude to, such as having to be hospitalized. So this is a model that we can use in order to help our customers to move from vaccine hesitancy to vaccine uptake. Now, so say your patient still decides not to get the vaccine. What you can do is to continue to emphasize the benefits of getting vaccinated. We can also provide them with educational information. We can share with them some trusted websites that they can go to get further information. We can give them brochures and handouts with benefits and risk about why they should get vaccinated. We can also work along with our community partners by hosting health fairs at various different churches and different organizations such as the AARP. Then you want to make sure that the conversation is documented in the patient's records. We should also set a plan for deferred vaccines. So we should have a plan in place where we can send out reminders or even give calls about needed vaccines. Then we should set up a plan to talk about this in the future. And we could lead into that by saying, well, I may not have been able to answer all your questions today, but perhaps we can discuss this again at your next pharmacy visit. Okay, so now let's look at case number 2. Now, Mr. Johnson is a 40-year-old man who has diabetes and severe chronic kidney disease. And he's here to pick up his medicine. So he informs you that he has been placed on the kidney transplant list because of his severe chronic kidney disease. And so you begin to ask about vaccines that he should get. And you ask about if he had received his flu shot. And he informs you that he received it at the health department earlier in the fall. So now, question that you might ask yourself is, what other vaccines should you recommend? And not only that, after you asked him about the flu shot, he stated that he has heard a whole lot about the Zoster vaccine, probably from commercials, TV commercials, and so forth. And so what we want to do is to first look at what vaccines, other vaccines you would recommend for Mr. Johnson. So I would definitely recommend that he get the pneumococcal conjugate vaccine, because end-stage renal disease is a high risk condition for invasive pneumococcal disease. Now, if you give him the pneumococcal conjugate vaccine as a patient with the highest risk condition, then he will also need the pneumococcal polysaccharide vaccine at least 8 weeks later. Now, Mr. Johnson has diabetes. Diabetes is a high risk condition for hepatitis B. So all diabetics under the age of 60 should receive a series of hepatitis B vaccine. Noting that he has end-stage kidney disease, not only does he need hepatitis B vaccine, but he needs a high dose hepatitis B vaccine. And depending on the vaccine that is used, that will determine the number of doses that he should receive. So for example, if you use Recombivax HB 40 micrograms, then 3-dose schedule is needed. If you use Engerex B 20 micrograms, then a 4-dose series is needed. Now, to his question about the zoster vaccine. So, I would sort of talk with Mr. Johnson and inform him that what we know about the incidence of shingles is that it goes up as you age. And we don't really know exactly how long the vaccine is going to provide protection beyond about 6 to 7 years. So my recommendation would be that he would wait until the recommended age, which is 50 years of age or older. And not only that, I would sort of explain to him also that if he could receive the zoster vax, but there's a great possibility that he may have to pay more out of pocket costs because it has not been recommended. It's not recommended for him at this time because he is only 40 years of age. So hopefully, after reviewing these 2 cases, we realize how important it is for us as pharmacists to use our pharmacy-based strategies to help us with vaccine and health disparities. So, additionally, for more information about resources that are available that you can use to help with increasing vaccination uptake and decreasing vaccine hesitancy. We have some links here in our presentation, such as the CDC's website has some patient education materials that you can use to give to your patients, or you can refer them to the CDC's website. Then there's the Adult Vaccination Resource Library that is put together by the Immunizing Organization. CDC also has what works to increase adult vaccination rates. And the APHA has a vaccine hesitancy guide that can help us in addressing vaccine hesitancy.
Thank you, Dr. Earls, for that excellent presentation. So in conclusion, healthcare providers are vital to addressing vaccine and health disparities. It is paramount that healthcare providers continue to communicate and effectively disseminate information about vaccinations to mitigate health disparities. Pharmacy and clinic-based strategies are needed to augment these efforts, particularly during the COVID-19 pandemic. So if you have any questions, please post them in the discussion board. Don't forget to take the post-module quiz as well.